Mainamoti Medical College. And before start of my discussion, I pray to Almighty God for the safety of my students and their peaceful lives so that they continue their study. Today we will discuss question about the GIT disease and liver disease. In the last 4 or 6 classes, we have discussed regarding question about the CVS, respiratory system, nervous system. And today we discuss the question about the GIT and liver disease. First question, a 55 years old female admitted in medicine department of Mainamoti Medical College with massive hematomas and melena for 1 day. Mention 4 causes of this condition. Four causes: first, bleeding peptic ulcer; second, rupture esophageal barrix; third, gastritis; fourth, carcinoma of the stomach. Second question was, what relevant history you will check for your diagnosis? History of upper abdominal pain, which is relieved by anti-ulcer drugs, such of peptic ulcer, and history of taking NSAIDs, which indicates gastritis. History of jaundice 6 months back, which suggests CLD. Abdominal distension, loss of appetite, lump in epigastric region indicates dyspepsia due to carcinoma of the stomach. Now, how to assess this patient? By examination, pulse, there may be tachycardia due to hypovolemia, and systolic blood pressure will be lower than 100 millimeter of mercury, indicates hypotension in hypovolemic shock. Skin will be cold, gummy, and sweaty. Tender epigastrium indicates peptic ulcer disease. Anemia indicates massive hemorrhage. And asserted jaundice is further telangiectasia, leukoplakia, all indicates chronic liver disease. And a lump in epigastric region also indicates carcinoma of the stomach. From investigation, hemoglobin will be reduced in case of anemia due to hemorrhage. HGBD may increase, bilirubin may increase, serum albumin reduced. All this in favor of CLD. Ultrasonography of the hepatobiliary system increased echogenicity of the liver in case of chronic liver disease. Upper GI endoscopy, esophageal varices in portal hypertension, ulcer in stomach in case of peptic ulcer disease, gastric ulcer and tumor in stomach indicates carcinoma of the stomach, where biopsy can be taken. So our first question is completed. Now our second question. A 35 years male patient admitted with the complaints of severe upper abdominal pain with several episodes of vomiting for 2 hours. Pain also radiates to back. Mentioned 4 differential diagnoses. And the 4 differential diagnoses is acute pancreatitis, acute peptic ulcer disease, polylithiasis, and polycystitis. Now, what investigation we can do for diagnosis of this patient? Blood serum amylase increased in acute pancreatitis. Serum lipase may also increase. ICT for H. pylori induced peptic ulcer disease. Upper GI endoscopy ulcer in stomach in case of peptic ulcer disease. Ultrasonography of the whole abdomen, swollen edematous pancreas in case of pancreatitis, gallstone in case of cholelithiasis, and thick gallbladder wall in cholecystitis. And now how we can treat this patient? Nothing by mouth or till further order, nasogastric suction, infusion 5% dextrose aqua 1 liter, normal saline 1 liter, and Hartmann solution 500 cc at the rate of 25 drops per minute for 3 to 5 days. And to relieve pain, injection timonium hydrochloride 1 ampule IV 6 hourly, or injection tramadol hydrochloride 1 ampule IV 12 hourly with injection ondansetron 1 ampule IV 12 hourly for 3 days. And injection pantoprazole 1 vial IV 12 hourly for 7 days. Injection ceftriaxone 2 gram IV daily for 7 days. Maintain intake output chart and monitor vital sign. Follow up the patient with ultrasonography to detect the complication and treat it. Now question number 3. A 35 years old obese lady presented with heartburn, water brush, and often provoked by bending, straining, and lying down. What is your diagnosis? Our diagnosis is GERD, gastroesophageal reflux disease. Our second question, name possible complication of this disease. Possible complication of this disease is Barrett's esophagus, esophagitis, anemia due to occult blood loss, esophageal stricture, recurrent chest infection. And management of this patient is pantoprazole 20 milligram, 1 tab BD, may require lifelong treatment. And some general measures, lifestyle modification, avoid fatty food, don't lie in bed after taking food, avoid smoking, weight reduction, and elevation of the head of the bed. And treatment of complications, endoscopic therapy, radiofrequency ablation therapy in case of Barrett's esophagus, and surgical resection of the esophagus in high-grade dysplasia of the esophagus, and blood transfusion in case of anemia. Now question number 4.
This conference will now be recorded.
A man of 32 years old complains recurrent abdominal pain. How will you assess his abdominal pain? Pain in upper abdomen relieved by anti-ulcerin, suggested peptic ulcer disease. Severe pain in upper abdomen radiates to back, which is constant, high intensity, and persistent for 10 to 15 minutes, suggested pancreatitis. Pain in upper abdomen radiates to right shoulder, indicates cholelithiasis. Physical examination, tender epigastric region indicates PUD, and tender right hypochondriac and positive Murphy sign indicates cholelithiasis. Investigation, serum amylase increased in acute pancreatitis, serum lipase increased, and ICT for H. pylori induced peptic ulcer disease, and upper GI endoscopy ulcer in stomach in case of PUD, and ultrasound of the whole abdomen, swollen edematous pancreas and pancreatitis, gallstone in polylithiasis. Fourth, systemic disease causing recurrent upper abdominal pain, diabetic ketoacidosis, anoxylate purpura, SLE, and abdominal TB. Treatment plan: nothing by mouth, digestive suction, infusion, IV fluid, and to relieve pain, diammonium hydrochloride, tramadol hydrochloride with ondansetron, pantoprazole, ceftriaxone, get the output chart, follow-up patient. For abdominal TB, treated by category 1 treatment, or anoxylate purpura, treated by steroid, for SLE, treated by steroid, for diabetic ketoacidosis, treated by soluble insulin and normal saline. Question number 5. A girl of 15 years is presented with profuse hematomasis. What is your diagnosis? Non-cirrhotic portal hypertension with esophageal paresis. Physical assessment of this patient, physical findings: anemia, pulse, tachycardia, systolic blood pressure low, splenomegaly, ascites, caput-medusa, hemorrhoids. And treatment: correction of the hypovolemia by blood transfusion, injection tardipacin at a 5 mg হবে না, 1 mg IV 6 hourly for 72 hours. After resuscitation, endoscopy and band ligation and sclerotherapy, and prophylactic propranolol 40 mg once. A name for complication of acute pancreatitis. So today, due to some unavoidable circumstances, I like to stop my lecture here, and in the next class I will try to complete this rest 5 question and question from the endocrine disease. So thank you, my student, for patient sharing, and I pray to Almighty God again for their healthy life and peaceful life, so that they will continue their study. Thank you.